me turn to our third speaker, Peter O'Halloran. He is the Chief Information Officer for ACT Health, which is the government agency responsible for the public health system in Canberra, Australia's capital. Peter is responsible for over 250 systems that serve over 10,000 staff who operate 3 public hospitals in that region with 1,000 beds and more than 40 community facilities. And certainly more than ever, community health is at the forefront of everything we think about. So his session today is going to cover the implementation of GS1 standard across the ACT Health Directorate and the ACT's COVID-19 response. So now let me welcome and turn it over to Peter.
Thank you, Kathy, and it's a pleasure to be here, everyone. Really, Kathy sort of emphasised who we are and what we do. What I would like to say is we operate public hospitals, but as the world of COVID came, we changed. And so ACT Health has been on the journey with GS1 standards for over a decade now. And we've built really strong foundations that we're really proud of. And it's nothing that's rocket science or very complicated. It's just simple elements that come together. And so we're using the various standards to actually identify a patient, whether it's on their wristband or on paperwork relating to them or specimen labels, to identify a staff member, and also to identify a location where care may be occurring, or for example, where maintenance staff might need to maintain something. And so our basic foundations are about who and where, which is where we're capturing the details about these elements. We've also then done more work on the what. What are we providing or giving to a patient? Is it, for example, a product, in which case we're very much focused on sort of using the GTIN standards, serialised wherever we can, or in fact also looking at if it's, for example, blood and blood products, and there's an example of a sort of transition label on the right-hand side there of going to the ISB T128 standard. We're also looking at asset ID cards and document types. So very much we have the who, now we've been building standards to do the what, so that we can actually capture all of these things. So we put all of those various things together and looked at it took us 4 or 5 years to do that across our public health system, not particularly fast, but we did it in a very measured manner that let us ensure that all our systems could cope with it, to ensure that everything was in place, so that as we rolled out clinical solutions, they would work and they would work the first time. So following that, we achieved a whole range of things. We put in place what we call positive patient identification. We reduced things such as wrong blood in tube incidents by 40%. And anyone who's ever seen what happens when there's an incompatible blood transfusion given to someone, that really is a dramatic reduction in potential harm for a patient, in fact, reducing the potential for mortality. We've done that. Secondly, what we've also done is we've very much speeded up a lot of our clinical processes. And these are just basic things of giving more time back to clinicians at the bedside, making things that are more efficient. We've also delivered considerable administrative efficiencies. And in the healthcare system, that's really not something that's valued so much by people. But when you look at it where we can have staff scanning processes where it sort of reduces their time by 80% in what they're doing, that's more time that can be put back into other elements of sort of providing those support services for patient care. And so we published a story on this a few years ago with GS1 now. And so anything you want to see about what we've done is available through the GS1 website. But really what I'd like to emphasise is this has just become a way of life for us. We can't imagine doing things without having these standards in place that simply let us know straight away who was involved in something, what was involved in something, and how we tie all those data elements together in our different systems and for reporting. And so that was something we've achieved. We're doing a whole lot of other digital transformation. And of course, then like the rest of the world, COVID hit. And so this is very much where we then changed a lot of what we did and went from running sort of public hospital systems and the public health system to also focusing on mass vaccination clinics, doing a lot of testing and also doing systems to manage contact tracing. And so we took all those standards we'd rolled out into hospitals in terms of the who and the what and the where that things were occurring. And for our vaccination clinics, and there's a photo of the first vaccination being given there to one of our nursing staff. We're very proud of that, just over a year ago, in fact, about a year and 2 days ago. And since that time, the systems we put in place have let us really provide highly efficient services for vaccination that mean that we have got our population to a very high level of vaccination. And so we're particularly proud of that. I think we probably claim to be the most vaccinated city on earth. It may be true. If not, it certainly makes a good headline in the press. But I think we're running at about 98.6%. So we're very fortunate that we've had both supply, but also the public confidence and trust. And GS1 stands are actually part of that public confidence and trust, in that our patients are confident that the product is available and appropriate and that it's safe, there's no quality issues. And they're also confident that we're actually recording their data correctly. And as we've had to, like other speakers have mentioned, sort of provide evidence of people being vaccinated and record the batches they've received and so forth, those standards have just come together as though it was something that we've done for the last 20 years, and it just worked well. So that was really where we've gone with it. And the foundations really set us up well for things such as suddenly gearing up to do over 1 million tests for COVID in our community. And we sort of set up drive-through facilities. And there's an example of one of our staff members here in the drive-through facility. And we're doing simple things like we're, once again, using some of those standards where we've sort of, in some cases for some of the testing sites, actually provided wristbands where patients were there for a while. In some of the drive-through ones, it's simply specimen labels or notes labels. You can actually see a picture there, the computer on wheels, which has the barcode label printed just sort of at the bottom right of the screen, and then using that positive patient identification to ensure that the sample really was for the patient that we were taking it from, that the collector, the staff member doing it, identified using the standards, and that the location ID was there. And that enables us to speed up the process dramatically of getting test results back to people. And at the worst times in where we're up to in COVID, when our testing services were being overwhelmed, it took up to 4 days to get results back to people in worst case scenarios. With all the technology we're using, in most cases now, we're turning those test results around overnight, and often people will wake up in the morning to have sort of received during the night a text message saying, your results are X. And really those standards and the technology is what's enabled us to do that and to provide people with that sort of confirmation that actually they're clear, or if they're not, that they have COVID, and that then we can guide them through what the next steps are. We also took it to something else, and Australia very much had a sort of a policy for quite a while now of largely trying to eradicate COVID or to contain it. And as some of you may be aware, we actually almost closed the borders to people coming in, and we've only this week, in fact, opened them up to the rest of the world, thank goodness. But what we also did then is have a very big focus on contact tracing. And so we required, every part of Australia required the various citizens to check in and record that they'd been at a location. So if there was an outbreak, we could trace everybody who had been there to identify what was happening. That sounds like a really simple, easy thing to do, but it really wasn't. And Australia, like many countries, sort of has 8 different states or territories or provinces, each of which decided to go their own way and not really think about how it would work for a citizen. And so this is once again where we actually simply turned to our standards and went, if we're going to do that, we created a simple QR code that people could walk up with their phone, scan the QR code and record that they've been there. We've written back to central databases so the contact tracers could be in touch if there was an exposure at that location. But we used, in Canberra, we used GLNs, the global location numbers, to actually record each of those individual areas. And that we did that for Canberra because that's what we do. We can't think of doing something without using a standard, just because it gives us a capability for the future. What we were surprised to then discover as we built the app, and we launched the first one of these in Australia, I think another state launched about 2 days after we did, was that there's actually demand from those other states to say, could we provide applications and support for them? And so we did it for 3 of the other jurisdictions in Australia, and you can see the different check-in screens there. But what it also meant was, because we used standards and GLNs, if I could travel to Tasmania or the Northern Territory or Queensland from Canberra, I could use my app from Canberra to check in at those sites. And I didn't need to download one for each jurisdiction. And to us, that was the true power of GLNs and the true power of the standards. I had interoperability out of the box because we just simply designed it using the standards. For the contact tracers who were trying to identify everybody, the benefit for them was that everybody checked in and the data was just there. So really, that was we thought, quite an amazing demonstration of the power of the standards. but also emphasised why it matters to build things according to standards from day one. We hadn't thought that we'd need to have this problem, and we built the application in 4 weeks and launched it straight away. Hadn't thought about that, but because we use the standards, it just worked when we needed to expand. And so that's really how GS1 standards actually helped us respond to COVID and protect our community. And as always, we like to learn from everybody else. And we have learned amazing different ideas of how to deal with these type of issues from other colleagues across the healthcare sector using GS1 standards. And so we've also, once again, partnered with GS1 to publish what we've done so that others can learn from what we've done as well. So with that, back to you, Kathy.
Thank you so much, Peter. And first, our gratitude to all the amazing frontline healthcare workers in your organization around the globe, and beautiful examples of both pre-pandemic, your 40% reduction in blood tube errors, and post, right? That contribution to all of your country. Those are just beautiful examples of what we're here to do. So thank you so much.